My patient was apparently asymptomatic 2 months back when he started to experience pain in the left loin region, which was insidious in onset, gradually progressive, with no radiation or no referral of the pain. The pain was in the left loin region with a dull aching character. There was no relation of the pain to micturition. It was there was no aggravating factor. There was, however, partial relief with the intake of analgesics, with gradual increase in dose of analgesics from last 2 months to now. There is no history of relation of pain to postural change. There is no history suggestive of hematuria, dysuria, calcuria, or passing of tissue bits in urine. No history of fever, nausea, vomiting. No history of any feeling of mass in the abdomen or any swellings anywhere else in the body. There are no history of any bowel disturbances. There is no history of noticing the swelling in the lower limbs or any history of trauma. No history of loss of appetite. There is, however, a loss of weight of 4 kg in 1 month. That is a significant weight loss. No history of any swelling which is seen in the scrotal area. No history of cough, hemoptysis, or bony pain, back pain, yellowish discoloration of eyes or sclera or skin. No history of headache or blurring vision. Past history, my patient is a known hypertensive. However, he's been recently diagnosed and he's taking amlodipine for last 6 months, and no other history of any TB contact or no other comorbidities or no other history of surgeries in the past. My patient consumes a mixed diet. He's a former smoker. He used to smoke 3 to 4 cigarettes per day for last 6 years. He quit 2 months back. There is history of alcohol consumption, 30 ml whiskey twice to thrice a week for past 15 years, and he's quit 2 months back. He's father of 2 children, and the sleep is disturbed because of last 2 months because of the pain. No history of any cancer or cancer related deaths in the family. Summarizing my history, my patient is a 42-year-old gentleman, painter by occupation, with persistent dull aching pain in the left loin for last 2 months, with no history suggestive of hematuria, noticing in the mass in abdomen or any scrotal region, no history suggestive of coughs or any distant metastasis.
Okay, so at the end of history, do you have any differential diagnosis?
So it's left loin pain. So this left loin pain could be because of any pathologies in the kidney area or in the colonic region. However, there are no GI symptoms, or it could be any retroperitoneal growth.
Okay. Yeah. So as per history, I don't think there's anything that to point towards any system. You can go on to examination. Any reason why you asked scrotal swelling?
Sir, in cases of any renal tumor, which is involving more so on the left side, a left side tumor is more since it drains directly into the IVC, it has more chances to cause left-sided varicocele.
What drains into the IVC?
The renal vein, the gonadal vein.
Yeah. Gonadal vein drains into the
renal vein, sir.
Yeah. Okay. And yeah. Okay. I think you can go on to examination.
Yes.
No hematuria. Now, suppose patient had hematuria.
Yes, sir.
Then what more would you ask in hematuria?
I'll ask him, sir, if it is a gross hematuria or did he suspected by some urine cytological examination, if it was a terminal hematuria or it was any hematuria which was seen at the initiation of the passage of urine, or it was a hematuria throughout the course that he was passing the urine, if there were any clots, and if there were any clots, what was the nature of the clots.
Okay, what would your type of nature of clot indicate? What are the types that you can expect?
Sir, if it is a upper urinary tract, if the bleeding is coming from the upper urinary tract, I'll expect it to be more serpentinous kind of clots. However, if it is from the lower urinary tract pathology, it will more be of a amorphous kind of clots.
Okay, right. Yeah, we can move on.
Yes. I examined my patient. I examined my patient in a well-lit room with informed consent, with adequate exposure, and in the presence of an attendant. My patient had a performance status of ECOG 1. His vitals were stable, and he was conscious oriented with no pallor, icterus, clubbing cyanosis, generalized lymphadenopathy, or dependent edema. The hydration status was adequate with no palpable supraclavicular lymph node. Systemic examination, I examined the abdomen, and on inspection, there was no localized area of fullness or distension seen. The umbilicus was centrally located. All corresponding quadrants were moving equally with respiration. There was a left renal angle fullness which was noted. However, the right renal angle was normal. There were no visible scar, peristalsis, prominent engorged veins or sinuses. Hernial sites were normal. External genitalia was normal. Bilateral supraclavicular region had no fullness. Yes, sir. On palpation, yes, sir.
Yeah, continue.
Yes, sir. On per abdomen examination, on palpation, there was no local rise of temperature. However, there was minimal tenderness which was noted in the left lumbar region with no guarding or rigidity. I confirmed my findings of inspection on palpation. There was a ill-defined, irregular, firm mass of approximately 10 into 9 centimeter, which was in the left lumbar region but spanning across left hypochondrial, umbilical, and left iliac fossa. Medial border was 2 centimeter above and lateral to the umbilicus. The swelling was not crossing the midline, and superior border was felt in continuity with the left costal margin. But however, I could insinuate my fingers between the costal margin and the mass. Lateral margin could not be felt. Inferior border was felt, which was 3 centimeter above and medial to the left ASIS. The swelling was mobile with respiration. It was bimanually palpable, however, it was not ballotable. It was less prominent on head raising test. It was not mobile, and it did not fall on the right lateral decubitus position. No other palpable organomegaly. On percussion, the left renal angle was dull on percussion, and no free fluid was noted. On There was no bruit on auscultation. External genitalia on palpation was normal. Digital rectal examination was also normal.
Okay.
This is the extent of the mass, and
This is 3 centimeters from the costal margin. You said 3 centimeters below the costal margin, right?
Yes.
Okay, anyways. ठीक है. Now tell me, summarize the examination findings and tell me your details.
Yes, sir. On summarizing my examination findings, my patient had a left lumbar region mass which was 10 into 9 centimeter, spanning across the left lumbar, hypochondrial, iliac, and umbilical region, which was mobile and which was non-mobile, not moving with respiration, not falling forward on the right lateral decubitus position. The inferior border could be felt well. It was bimanually palpable. My most probable diagnosis are, sir, a left renal mass, probably malignant in nature. The other diagnosis that I would like to give is a retroperitoneal mass.
Okay. Any others? DD?
Uh,
Anything? Any other organs?
any
Why is it not a splenic mass?
Sir, it's not a splenic mass because on examination, I was able to insinuate fingers between the costal margin and the mass.
Okay.
And it did not grow in the splenic line, sir.
Okay. Okay, right. Okay, so your diagnosis is a left renal mass, and you can. And why do you say it is malignant?
Sir, because it has a short history of 2 months, and the mass has achieved a huge size in spanning over 2 months because of rapid growth, because of his age. There are other points in history which could point towards a renal malignancy, like his occupation. He's a painter, he's elderly, he's recently diagnosed hypertensive, which could be one of the paraneoplastic syndromes. These were certain points which and in examinations are also it was a big mass.
Hard mass, right?
Yes, sir, hard mass.
Yeah. Any hard mass, first thing you can tell. First thing, it is a hard mass. So he was a smoker, right?
Yes, sir, he's a smoker.
Yeah, smoking, that is another risk factor. What are the risk factors for renal mass?
So a renal mass can have risk factors like
RCC, basically.
Yes,
so
sir.
You can tell my differential diagnosis is a malignant renal mass, probably renal cell carcinoma.
Yes, sir.
Yeah, risk factors.
Risk factors are smoking, some occupational risk factors like people who are working in the any painting industries or dye industries, obesity, hypertension, any known syndromes which can, however, they do not present in this age group, and some underlying kidney disease.
Yeah. Okay. Okay. Now, how will you proceed next?
Sir, as an extension to my clinical examination, I will do certain investigations like ultrasound, which will help to localize my. I will like to confirm my organ of origin and to look for any other features like ascites or any other metastasis, and other investigation to confirm my diagnosis. After ultrasound, I would like to do a CT of the abdomen and pelvis with urine analysis.
Okay. Do you have reports, or we'll just discuss like arbitrary
I
findings?
have CT findings, sir.
Okay.
Yes, sir. So this is yes.
Yeah. Now you can even say directly you can go for a CT, and I don't think anyone will object at this stage that when all investigations are available at your hands and you also have primary suspicion is a malignancy, you can directly go for a CT. And anything else in CT on the abdomen?
CT of the abdomen and pelvis, sir, and HRCT of the chest.
Yes. Okay. Okay. Right.
So this is a axial section of my patient. In this axial section, we can see a mass which is arising from the left kidney.
The image is there?
Sir, I put the image, sir. It's not visible, sir. Okay. There is a mass which is arising from the left kidney, and it's arising mostly from the posterior aspect and more in the lower pole, arising from the posterior lower pole, and it is a hypo intense lesion, which the renal vein from the left renal vein can be seen illuminated. There seems to be no thrombus in the left renal vein, and there seems to be no other lymphadenopathy in the retroperitoneal region.
Hypointense, hyperintense, in which imaging would you describe hypointense and hyperintense?
On an MRI, sir.
Yeah.
This, yes, sir, it is a hypodense lesion, sir.
So yeah, enhancing, whether it is uniformly enhancing?
No, sir, it is irregular mass, which is it is a irregular mass which is enhancing, and the fat planes with the
is it uniformly enhancing or no? Can you just point with a pointer which is the mass?
Yes.
I think it's not.
Peripheral enhancement is there, na sir?
Yeah, that's a heterogeneous enhancement. Okay, that's how you would typically describe it. Then any other findings?
Yes, sir. Sir, this is the mass, sir.
Yeah.
Yes, sir. And the fat planes with the psoas muscle seems to be intact, and there is no invasion of any vessels. The surrounding bowel seems to be free, and there is no ascites that is visible. The available sections do not show any liver metastasis. The fat planes with the anterior abdominal wall are also intact.
Okay. Now, something additional which I would say is that this has some hypoenhancing areas, large areas of hypoenhancement, which probably could indicate
necrosis.
Yes, necrosis or
cystic components.
Okay, yes, very good. So, do you know any classification for cystic renal masses or renal cysts?
Yes, sir, the Bosniak classification.
Okay.
It grades from 1 to 2F, 3 and 5. In a simple. Yes, sir. 3 and 4, sir. There is a simple cyst is Bosniak 1. It does not warrant any form of surveillance, and the risk of malignancy is negligible. Then is 2. Type 2 cyst has hairline septa, thin septa, less than 3 centimeters tumor. And if it is thin hairline septa, it does not warrant any other further surveillance. In certain tumors which have thick septa, in 2 and 2F, they warrant active surveillance. In 3, it is tumor more than 3 centimeters with solid components. So hypodense.
No, solid is not 3. 3, there is measurable enhancement. Okay, you have to remember this word. There is measurable enhancement.
Yes.
In up to 2, there is no measurable enhancement. 2 and 2F. Okay, and then you have thickened septa, thickened calcification, bigger calcification, all that is there. But what differentiates between 2 and 2F is a measurable enhancement. Now, if you see the wall, the cyst wall, okay, so it is enhancing, and when you find the Hounsfield unit, you will be able to measure that over a non-contrast. Now, why would you do a non-contrast? What is the protocol for a CT in this thing, urology, CT urogram, as you say?
So we take a non-contrast image first.
Okay.
After that, I'm not aware of any protocol as such.
Okay, so there are 3 phases of it. One is a nephrographic phase. Okay, first is the non-contrast, then is the nephrographic, and then sorry, I'm forgetting. Nephrographic, more is then followed by the delayed. Anyone else remembers?
Timings are different, sir. I think it's not a pure triphasic. Timings are different.
Yeah, timings are different. It's called nephrographic phase and one second. nephrographic, corticomedullary, and delayed phase.
Yes.
So it's pretty much similar to your portal. Your liver triple phase only. The main in the nephrographic phase, we see the enhancement of the kidneys, and that time the vein also we are able to see the vein in that phase whether there is any. So if there is a thrombus in the vein, what will you see it as?
Sir, thrombus can be seen as any vein contour irregularity, or it can be seen as non-enhancing kidney also, because the contrast cannot go through, or
There will be a filling defect in the vein.
yes, sir.
Okay, and many times the vein also is also dilated because of the thrombus.
Yes.
Okay. So nodes are also not there.
Yes.
Right. So you need to first, before you describe the city, first you have to tell this is contrast or non-contrast. Then you have to describe from what areas it is taken from the, say, the diaphragm to the pelvis. Okay. And then you start describing the features, which is the mass. Then you then about the enhancement, then about the vessels. Okay. And then in the delayed phase, you have to comment on the ureter. I think that image is not there. So the 5 to 15 minutes that take the delayed phase, and that is where you see the collecting system. Okay. Now, what is the use of the non-contrast phase?
So these any form of calcifications we can see.
Yeah, better seen. Another is the angiomyolipoma.
Yes.
Okay, so angiomyolipoma, because it is a fat density tumor, it is diagnosed based on a non-contrast phase only.
Yes.
Okay. Then in the chest also you have to see for any metastasis. Whether you would go for a CT or a PET.
Sir, I'll go for a CT because PET can cause a lot of background. Since the contrast is secreted from the kidneys, it can cause a lot of background noise, a lot of background enhancement, sir.
Okay, PET is not indicated as such. As such, renal masses, do they have good uptake?
No, sir, they don't.
Renal masses do not usually have a good FTG uptake. Then and also a good CT abdomen with the chest is good enough, and you usually do not PET CT. Then what is the best investigation for a IVC thrombus?
MRI, sir.
Okay. So usually MR venogram.
Okay, sir.
But right now you can also say that with the advanced CTs, with thin slices, CTs almost as good as a PET, as a MRI.
Yes.
Okay. Okay. Next.
So this was the report of the CT. It was a 9.3 into 7.9 into 9.2 centimeter heterogeneous solid cystic lesion, predominantly exophytic, involving left pole of kidney with predominant exophytic component. No renal IVC thrombus noted. No distant metastasis.
Right.
Yes.
What will you do next?
Sir, after confirming my diagnosis and staging the patient, if it is now radiologically it is a T2N0 disease, sir. Now I will like to do certain other investigations like a CBC and an LFT to make sure that other parameters are not deranged, which are often seen in the renal cell carcinoma, sir.
Just CBC and LFT?
No, sir, other profiles as well, sir.
Okay.
And then, sir, we'll plan for the surgery, sir.
Okay. Right. Okay. So, what surgery are you going to do?
Sir, this is a T2N0 with predominantly exophytic component. We can calculate the renal score or any. We can calculate from any nephrometric index the probability of complications and the complexity. The complexity. Yes, the complexity of the surgery. If feasible, we can do a partial nephrectomy. Otherwise, a radical nephrectomy. Sir.
Okay. And what approach?
We can take the laparoscope. If the facilities are available, we can take the.
It is available everywhere now.
Yes, laparoscopic or robotic approach, or even an open approach if the facilities are.
What will be your approach?
So open radical.
You have finished your MCH and then you have joined a hospital. This patient has come to you. What will be your approach?
An open radical nephrectomy.
Okay. And what would be your position and incision?
My position, we can go by the anterior approach. So then this position will be supine, and the incision will be a midline incision or a chevron incision.
Midlines, don't tell the midline incision for a renal mass. They're extremely difficult to operate. So you can go for a supine, or you can go for a lateral position also.
Yes, sir.
Okay, so you can go for a subcostal anterior approach. You can go for a flank approach. Okay,
Yes.
Extraperitoneal or retroperitoneal flank approach, where you may also need to cut the rib. Okay.
Yes, sir.
And in supine position, you can go for anterior subcostal, or you can go for a chevron or a makuchi,
yes,
depending on the complexity. Okay, so which one do you choose?
Makuchi incision, sir.
Okay, but sometimes makuchi is for more complex tumors. This probably may not be such a complex tumor. If you are exposed to good number of open renal surgeries, then usually a lateral approach or lateral flank approach is quite good. The 12th rib approach. So you put the patient in a lateral position and then you break the table. There's a kidney bridge in the table.
Yes, sir.
Put it in the opposite, against the opposite 12th rib, and then you strap the patient and then you break the table at that point. So the idea is to stretch the flank.
Okay, sir.
So that you get a good amount of exposure. Now we start the incision around the 12th rib and extend it anteriorly. And now, do you know about this approach?
No, sir. I haven't seen this approach.
Okay. Right. So then, okay, then we will discuss what you are comfortable with. So proceed with supine position, and then what is the incision? Makuchi.
Yes, sir.
Okay, Makuchi. Okay. So you can describe the steps.
Sir, after giving the incision and after entering the peritoneal cavity, sir, we will mobilize the left side colon.
Okay.
And we'll mobilize it medially, and we will be able to see the kidney with the gerotas. Now we'll trace the ureter with the kidney, and we'll mobilize the ureter from the retroperitoneum and go towards the hilum. From the hilum, now we will trace the renal artery and the renal vein towards their origins. And after we've found the renal artery and the draining.
Which one will you find first?
The renal artery, sir. We'll find the renal vein, sir, first, but we'll take control of the renal artery first.
Yeah, you will always find the renal vein first. So it is VAN, vein, artery, and then
Ureter.
VAT, vein, artery, and tube.
Okay, sir.
Always vein first. If you are finding the artery first, then be highly suspicious that it could be the which artery?
Gonadal.
Artery.
Artery first.
Superior mesenteric artery.
Okay, sir.
Okay, if you've not gone in the correct lane, what happens? The mesenteric vessel, it will be just cranial to that, and you may think that it is the renal artery, and then it is actually it could actually be the superior mesenteric artery.
Yes.
Okay, then you found the vein. What will you do?
We'll loop the vein, sir.
Yeah.
And then we will dissect the artery. And after we found the artery, we will ligate and divide the artery. Following that, we will ligate and divide the vein and the ureter. And then after we'll dissect the kidney of its retroperitoneal attachments.
Okay.
And if there are any enlarged nodes, in this case there are no enlarged nodes. So we'll take out the kidney along with the gerotas.
Okay. Would you go for a lymphadenectomy?
In a T2 tumor, sir, with no clinical findings or no radiological or intraoperative enlarged nodes, I will not go for a lymphadenectomy.
Okay. So in what cases do you do a lymphadenectomy?
Sir, in the patients who have a radiological node positive disease or intraoperatively enlarged nodes or a T3, T4 disease, in those patients, I will like to do a lymphadenectomy.
Okay. So is there any criteria for a lymphadenectomy?
Not aware of the criteria, sir.
So Blood's criteria.
Yes. Okay.
Okay. So T3 N plus sarcomatoid variant, T3 T4, and few others. I've also forgotten some of them. So that's called Blood's criteria. I should know that.
BLUTE, sir.
Yeah, BLUTE or ET? BLUET, I think.
Okay, sir.
I'll just check it. Yeah, BLUTE, Blood's criteria. Okay, so okay. Now, okay. Patient, then you close it. Patient recovers, goes home, comes back with a biopsy is there, or we shall have a arbitrary discussion.
Don't have the biopsy, sir.
Okay. Now, this has come as renal tumor. It has come as T3. Okay.
Yes, sir.
Ferman grade 3. Okay.
Okay, sir.
Clear cell RCC. Okay. All margins are clear.
Yes,
Now
sir.
what?
Sir, there are a few. We can keep the since it's a grade 3 tumor, we can discuss the options of adjuvant therapy.
So what is T? What comes under T3?
Sir, T3 is if the tumor is invading the renal vein or the pelvic alical sinuses or the renal fat, perirenal fat.
Okay. And there is something ABC.
So A is an IVC thrombus. If IVC thrombus is below the diaphragm, it is B. If IVC thrombus is above the renal diaphragm, if the IVC of thrombus is above the diaphragm, it is C.
Oh yeah. Okay. So it's come as invading the renal sinus fat and T3 Ferman grade 3. Now what?
We can discuss the options of adjuvant uh, adjuvant immunotherapy or adjuvant tyrosine kinase inhibitors with the patient, sir.
Okay. Now this patient is cash constrained. So what will you offer him? Or what will be? He said, I don't know, you suggest. मेरे पास पैसे कम है, आगे क्या करना है?
Uh, sir, this is a clear cell, sir.
Yeah, clear cell T3, Furman grade 3. Margins clear, node negative, we have not done.
So we can consider capecitabine based chemo, sir.
No, there is no capecitabine for renal masses. Tyrosine kinase inhibitors you were telling, na?
Yes, sir. Sunitinib we can consider, sir. Adjuvant sunitinib.
Okay. So any trial that supports this?
Sir, the S-track trial, sir.
Yeah, S-track trial is the only trial. There are around 5 trials for adjuvant TKIs in high risk RCC. The only one that supports this is S-track trial, and that's why whether you would strongly recommend this or you would just say that there is some evidence, whether it is a strong recommendation.
Sir, there can be we can consider surveillance if the patient is. It's not a strong recommendation, sir.
Yeah, it's not a strong level, no level 1 evidence to support TKIs. What about now if he has all the resources? Anything else you can?
Pembrolizumab, sir, we can give.
Okay. What would you give? How would you give?
Uh,
Which, based on what? What is the
uh,
anything that supports pembrolizumab?
it's a keynote trial, sir.
564.
564, sir.
Yeah. So, is there any OS advantage?
Sir, not aware, sir.
Okay, so until couple of months, I think 2-3 months back, there was no OS advantage it was shown in any of the trial, but they have come up with the latest reports, latest analysis, and they are showing that there is some OS advantage in pembrolizumab. So based on that, you should recommend pembrolizumab for a adjuvant for high risk RCC. What are high risk RCC?
Sir, the RCCs which are either non-clear cell or have some sort of sarcomatoid component or high grade.
Okay, non-clear cell, high grade, grade 3, grade 4, sarcomatoid variant. These are the ones, T3, T4.
Okay, sir.
Okay, these are the ones that will be considered as a high risk RCC, and you would ideally give them. The recommendation is not there for TKIs, but recommendations are there for pembrolizumab. Pembrolizumab, how much would you give? 200 mg, 3 weekly for how much time?
3 months.
2 years.
Okay.
Okay. And what is the cost? What will be the cost of this treatment? He will ask you the next question.
So I think it is for one cycle it is around 1 to 2 lakhs.
Okay. So with all the patient support programs, it has come down. Now they will ask you if you're routinely giving immunotherapies in your institute, then they will know that whether you have when, because all these things comes next, and when you start your practice, these are the things that the patient will ask you first. So it's around 10 lakhs per year, 10 to 12 lakhs per year they will have to uh, give for this. Okay, so how will you follow up this case?
Sir, I will after we've done the surgery, we will call the patient every 3 monthly for the first 2 years, and after that 6 monthly for the third year, and annually thereafter.
Yeah. And what investigations would you do?
So every time the patient comes, I will do history and physical examination at every visit, and once annually, sir, we can do CT of the abdomen, sir, with chest X-ray, sir.
Don't say we can do. Just tell them I will do. Alternate simple protocol is alternative. One time you do ultrasound and a chest X-ray. Alternatively, the next visit you do a CT scan. Then again, next time is a ultrasound and a chest X-ray.
Okay, okay, sir.
Now, 1 year down the line, he develops a node in the lungs. Okay.
Yes, yes, sir.
So, what will you do now?
Sir, if the DFI is more than 12 months, and that is the only site of disease that is there, I can go up for. I would like to uh, consider a surgical resection of the metastasis, sir.
Okay. Okay. Now that is not possible to operate. It's in a very critical area. It is in a hilar area. It's not possible to operate. What will you do?
Uh, we can we can give we can give second line. We can give second line chemotherapy to the patient, sir.
Okay. What are the first line?
Uh, So Pembro and Axin. First, we'll see what is the since this is now a metastatic disease or recurrent disease. I will further risk stratify the patient on the basis of the available risk stratification criteria, the MDACC criteria or the IMDC criteria. Uh, if it is a low risk disease, then I can give the patient Pembro with Axin.
What is IMDC criteria for?
So it is for metastatic. It is for stratifying the metastatic disease, sir.
Yes. And for what? What would you after stratification? What would you? That is for a upfront metastatic disease.
Okay, sir.
Okay. In upfront metastatic disease, whether to do a nephrectomy, cytoreductive nephrectomy or not, is IMDC. We will do the stratification. Any other such stratification? This thing is there.
Sir, MSKCC, sir.
Yeah. Okay. So now see, when you're very sure only you speak. Now once you opened up this topic, so he might go into a metastatic RCC, examiner. So okay, so metastatic RCC patient. Now suppose the same scenario, patient has come with a lung nodule. What would you?
Uh, if only lung nodule and
Because like, he has presented you first time with this and a lung nodule.
we can go, sir, for resection of the lung nodule as well as with
Based on what? Based on what? It's a very common clinical scenario that comes. Renal mass with metastasis in the lungs, and how would you decide whether an nephrectomy or not?
Yes, sir, we'll go for the nephrectomy, sir.
Why?
Sir, because of so metastatectomy also gives good survival, sir.
What trial suggests that?
Sir,
What would be your criteria?
sir, a DFI of more than if upfront, sir, the patient has a
Yeah, upfront. Same patient has come with a metastatic node. So in all cases, will you do a cytoreductive nephrectomy?
No, sir. No, sir. There is
In
a.
what cases will you do a cytoreductive nephrectomy?
Sir, there was a certain trial which showed that we can give the patient sunitinib, and after the patient has responded well to sunitinib, there has been no disease progression. We can choose patients who have responded well for cytoreductive nephrectomy.
Okay. So basically, what you do is that IMDC risk stratification. If it is a IMDC good risk, okay, with only one risk factor, then
Yes.
you should go for a nephrectomy.
Okay, sir.
Okay, and in cytoreductive nephrectomy, at least there should be a more than 70% debulking of the entire metastatic volume.
Okay, sir.
Okay. Um, then what does the Carmina trial tell?
So the Carmina trial had two arms. One, they were also considering stage 4 RCC, and in the two arms, in one arm they gave only sunitinib, the other arm they gave sunitinib with cytoreductive nephrectomy. There was non-inferiority of sunitinib with as compared to sunitinib with cytoreductive nephrectomy.
Yeah. So only when there is a IMDC good risk, then only you will go for a nephrectomy. Otherwise, it's systemic therapy. Okay.
Okay.
And
Yes.
then there is some interim results that are showing that even in an intermediate IMDC risk, you can go for a nephrectomy. Okay.
Yes.
And now suppose this guy had IVC thrombus.
Yes, sir.
Do you know about the levels of IVC thrombus?
Yes, sir. There is the niche criteria for IVC thrombus. Type 0 is thrombus only in the renal vein. Type 1 is thrombus in the renal vein and IVC, which is less than 2 centimeters from the from the drainage of the renal vein. Type 2 is more than 2 centimeters from the renal vein. Type 3 is it is above the hepatic vein but below the diaphragm, and type 4 is above the diaphragm, sir.
Okay, right. Now you have a patient with not a type, it's level.
Yes, sir. Level, sir.
So level 1, 2. Now you have a level 2 thrombus.
Okay, sir. Yes, sir.
So how will you how will you approach change for the surgery?
So in a level 2 thrombus, we'll have to mobilize the IVC, and uh, we won't have to take the Pringles maneuver. We'll have to mobilize the IVC, and then after also control the lumbar veins, and after that, sir, after we fully mobilized the IVC and taken control of the lumbar veins, we will apply clamps.
Okay.
This is a left-sided thrombus. We'll apply clamps first inferiorly, then towards the right side, and then superiorly.
Okay.
We will do the nephrectomy. Along with that, we will uh, also take out the clot, the thrombus, and the removal of clamps will be opposite to the application. It will be superior, opposite, and inferior.
Okay. Right. How would you close the IVC?
Uh, with a non-absorbable, continuous non-absorbable sutures.
Yeah, I can, like, which one? What to use?
So PDS.
Proline. PDS is absorbable, not
Yes,
absorbable.
proline, sir. Yes.
Yeah, proline. And just before closure, do you do something? Have you seen IVC being opened?
No, sir.
Okay. So just before your closure, do you do something? Just before you finish the closure.
Valsalva, sir.
No, something else. So you would put a small tube, like an infant feeding tube, inside the IVC. and you will first take out the air. You will flush it with something.
Heparin, sir.
Yeah, heparin saline. Okay, right. So
So before closing, we have to do that.
yeah, like you start the closure. Just last two bites will be there. That time you put in the feeding tube. You flush. Now there will be some air inside it. You flush the entire thing with this heparin saline, and just as you're flushing, you just take it out and immediately take the next bite and close it. Okay, then
So heparin concentration same we are using for microvascular surgery or something else.
just like they add in 100 ml, they will add 1,000 units of heparin, something like that. There's no fixed protocol as such. Just 1 or 2 ml in 100 ml NS.
Okay.
Then what else? Okay, and what about the renal scores? What renal scores are you aware of?
Sir,
I mean, sorry, your nephrometry scores.
sir, the renal score, the Padua score, and the nephro score, I think.
So then one more something in C index.
Yes, sir.
Okay. Um, then just 1 second. I'm getting a
Yeah.
call. Okay.
Yeah. Yes. So there are two different things that I have read it at two different places. Most of them say that we should apply IVC below, opposite, and then superiorly.
Yes,
And
IVC below, opposite renal, then cranial.
and sir, taking out, sir.
Taking out is also in the same order.
Okay, sir.
Below, opposite, and cranial.
Okay, sir.
So something else. Okay, small renal masses. What will now this if this mass was say 3.5 centimeter?
Yes, sir. So in case of a small renal mass, if there are no other high risk features on status or has a lot of comorbidities, we can consider other modalities like HIFU or radio frequency ablation, or we can even consider surveillance for this patient.
Okay. So what are the criteria for active surveillance?
Ultrasound every 3 monthly.
Before telling him that before ultrasound is 3 months later.
Yes,
At the when you decide that this case is you want to do for active surveillance, what something you need to do before confirming the modality. We need to confirm that is a clear cell variant.
Yes, sir. Biopsy, sir. We'll take a biopsy before putting the patient on.
Yes. So, what are the indications of biopsy in a renal mass?
Sir, if it is a metastatic disease and we have to give systemic therapy, if we have to keep the patient under surveillance, or if we are suspecting any if we are suspecting lymphoid lymphoma, sir.
Lymphoma, metastasis, confirmation of a metastatic to the kidney before starting active surveillance.
Before RFA, sir?
Before RFA, yeah, before RFA also. And even in sometimes tuberculosis, sometimes there is a confusion whether it is a renal mass or malignancy or this thing. So around there are 5 indications of renal mass biopsy. Now, why do we do active surveillance? What are the chances that what are the possibilities that it could be benign, it could be indolent, or it could be aggressive?
Sir, we say that whenever there is an increase in size, the chances of becoming being malignant increases with every centimeter increase, and the chances of less than 4 centimeter are being malignant is, I think, less than 3 to 4%.
So 20% benign, and something like 60% indolent, okay, and 20% aggressive variants, something like that. I've read this, confirm it once.
Okay, sir.
And okay, partial nephrectomy. How would you do? Suppose if you had to do a partial nephrectomy.
We'll prefer doing a minimally invasive approach, sir. And if you're doing a robotic or a laparoscopic, we'll after getting the peritoneal access, we will mobilize the colon, and after mobilizing the colon, after exposing the kidney and the gerotas, we will dissect the ureter down.
Criteria is not minimal. Criteria is executing a partial nephrectomy. Approach is secondary.
Yes, sir.
First criteria is doing a partial nephrectomy. It should not be that you were able to do a open partial, but you have ended up doing a laparoscopic radical.
Yes, sir.
Okay. So
Yes.
the idea has to be preservation of maximum number of nephrons.
Yes, sir.
So is there any other name to it?
Uh,
A partial nephrectomy?
Nephron sparing.
Nephron sparing surgery. And are there any types of all this?
Yes, sir. There can be enucleation, wedge excision,
enuclear resection also.
Okay, sir.
Okay. So how exactly do you do enucleation?
So after we've dissected the after
you've gone down to the plane of the kidney.
Yes, sir.
And you see a partial exophatic tumor.
Yes, sir. We'll dissect off the tumor. We can take the help of intra-op ultrasound is available, and we'll do the parenchyma. We will start dividing the tumor of the kidney parenchyma, and after complete excision has been achieved, we will like to close the rest of the liver, rest of the kidney parenchyma.
What happens to the blood vessels? You'll be bleeding throughout.
So the blood vessels which are feeding to the tumor, we will ligate them, sir.
No, what about the kidney blood vessels?
So we'll take control of the kidney blood vessels, not ligate them.
Yeah, obviously not ligated. How will you control it?
We will take a red rubber loop, and we'll take a vascular control of them. We'll put a clip onto the red rubber loops, and
no, you have to clamp the vessels.
Yes, sir. The ischemia times.
Yeah, you have to clamp. So you have to put vascular clamps at least on the artery.
Okay, sir.
Okay, the artery has to be clamped. There's something called a super selective clamping is there, where you find the the segmental branches, and you can dissect the hilum, and you can, if it's a hilar tumor, if it's a polar tumor, and you can see particularly that this particular feeding vessel has to be there. Suppose the upper polar mass, and you find the upper segmental branch, so you can just selectively clamp that upper segmental artery and then do a enucleation. Now for enucleation, the most important thing is getting into the enucleation plane. There's a fixed capsule, there's a good capsule that is formed around the renal mass. So you have to find the capsule and you have to dissect in that plane. And most important is your assistant, who will help you in the suction and irrigation and show you the correct plane. Okay. And then you have to do the renal therapy. Ideally, try to finish everything in the or ischemia time should be less than 25 minutes is what
Yes.
is in the books. But in practice, getting a good enucleation followed by closure is the most important. Don't bother about the time. We have done many times for for 1 hour, 1 hour, 10 minutes also, but the kidney also survives after that. Now, very recently, we had done one partial nephrectomy. So, while suturing, what happened? We probably have taken a bite of the renal artery branch within the parenchyma, and then the kidney looked very, very. It was not like a normal color kidney; looked very congested and something like that. So, anything interop that you would use to help you identify whether it is a good vascular kidney or not, whether to take the decision whether to keep the kidney or remove it in such a situation.
We can do ICG.
Yes. Yeah. So you can use ICG. If it is a good enhancement is there, then probably you can retain the kidney. And yeah, anything else that you think we've missed?
Uh,
So without ICG, we cannot decide. Yeah.
Yeah, I mean that's when you have ICG available. No, it's not like it's absolutely required. Now, for a situation where you think that the vascularity might be compromised, okay,
Once
then
we
ICG.
operated a huge retroperitoneal sarcoma, and it was arising from fat, perirenal fat. At that time, we had separated full gerotas, fascias, and everything, and the kidney was like hanging. The color of
Okay.
kidney was not good, but well, our consultant might have experienced, so he said it is okay, it will become normal. And while closing and washing and putting drain everything, uh, kidney was become okay. To how to decide, and we kept that
So,
warm
so many times, what you have is the artery goes into spasm. Okay, and over time it comes down. So you can give it some time, around 10 minutes or something. And then one thing is. If I mean for us ICG was the available, so that is pretty much tells whether the kidney is vascular or not. Otherwise, the kidney should be the it should not be very soft. Okay, once the vascularity is not there, usually it becomes soft, and otherwise a good vascular kidney is quite firm to touch. Okay, and then the typical color of the kidney, that also.
okay.
Sir, should we, in cases of tumors which are confined to kidney in T1, T2 tumors, is it okay for even largest tumors if it is a 10 centimeter or more than 10 centimeter big tumor we've seen, if we have it in the exam? Then saying that we will consider doing a nephrometric score for this patient, is it okay, or should for large, if we get large palpable masses in the exam, should we tell them that we'll go for radical nephrectomy itself?
Now it all depends on how much kidney can be preserved. At any point, if you feel that usually large masses will be advanced, they'll be T3. Many of them will be T3, invading the perinephric fat, invading the pelvic LSS system. So if it is a T3, you should not attempt a partial nephrectomy. Any indication that is there on imaging that says that it is a T3 disease, then do not attempt a partial nephrectomy, go for a radical nephrectomy.
Okay, sir.
And you can also say I will attempt a nephron sparing surgery intra-op if I feel that the tumor is invading the renal sinus or invading the pelvic LSL system, then I will convert it to a radical nephrectomy.
Okay, sir.
Okay, anything else? If you think any questions are there, anything we missed, I think you can send the questions.
Okay, sir.
Then we can discuss.
Okay, sir. Thank you so much, sir.
Okay.
Thank you, sir.
Thank you,
Okay.
sir.
All the best.
Thank you, sir.
Okay, thank you.